Good morning all. Today we will be discussing another question paper of periodontology. It's for the year 2018 and in this we will be discussing section 1. Question paper is given here on the screen, section 1 and section 2. Coming on to the question paper of section 1. Describe theories of shock absorption of periodontal ligament and short note. Discuss various indices that measure gingival bleeding, define and classify gingival enlargement, differences between localized and generalized aggressive periodontitis, discuss periodontal manifestation of AIDS, sign and symptom of periodontal pocket, and then followed by one-liners. Coming on to the long question. First of all, we will be discussing the long question. Since it's a long question, we will be writing content. In the content, we will be writing all the points that we will be writing in the answer. So, first of all, introduction followed by definition, composition, diagram, functions and theories. Introduction. The attachment apparatus of the tooth is composed of periodontal ligament, cementum, alveolar bone and gingiva. Definition of periodontal ligament. Periodontal ligament is a unique, multifunctional, soft, specialized connective tissue present between the root of the tooth and the bone, forming the socket wall. We can write synonyms of the periodontal ligament: periodontal membrane, alveodental ligament, desmodont, pericementum, dental periosteum and gomphosis. Cells of PDL. It is up to us whether we want to write after the definition synonyms or cells of PDL, but since it's a long question, if in order to gain good marks we should write some additional points. So it's up to you, it depends on your speed. So coming on to the cells of periodontal ligament, connective tissue cells will be there. In this, synthetic and resorptive cell will be there. Synthetic cell, fibroblast, cementoblast and osteoblast will be there. In resorptive cell, osteoclast, fibroblast and cementoblast will be there. Now next is epithelial rest cell. Epithelial cells of molluscs, undifferentiated mesenchymal cell. Then defense cell. In defense cell there will be macrophages, mast cell and eosinophil, and then neurovascular element. And we should draw one diagram. Function of periodontal ligament: supportive, sensory, nutritive, hemostatic and eruptive. Coming on to the shock absorption, the proprioceptive nerve ending in the ligament form part of extremely refined neurological control of mastication and thus protect the ligament from damage. In addition, blood supply, the ground substance and the collagen bundle all take part in the absorption of functional stresses and their transmission to the alveolar bone. Coming on to the theories of shock absorption. Tension theory, viscoelastic and thixotropic theory. Tension theory. When force is applied to tooth, the principal fiber unfold, they straighten and then they transmit the force to the alveolar bone, causing elastic deformation of bony socket. When the alveolar bone has reached its limit, the load is transmitted to the basal bone. Major drawback of the theory is it is found to be insufficient in explaining in experimental evidences. Viscoelastic theory. The next theory is viscoelastic theory. This theory describes the vascular ground substance complex as a shock absorbing system. That means the shock that is there on the tooth will be absorbed by the vascular ground substance, and the fiber bundle system as a suspensory system limiting tooth movement and transmitting strain to the supporting bone. The displacement of tooth is largely controlled by fluid movement, with fibers having only a secondary role. Thus, when a force is applied to tooth, series of events will be there. First is initial displacement of tooth is associated with intra and extravascular fluid movement, and then the foramina are more in the cervical third of tooth than the middle and the apical third. Basically, in step 1, what will be there? The initial displacement of tooth is associated with intra and extravascular fluid movement from the periodontal ligament to the marrow space of the bone through foramina in the cribriform plate, and these foramina, they are more in the cervical third of the tooth. And then After the depletion of tissue fluid, the fiber bundle, they absorb the force, they slack and tighten. This lead to the blockage of they lead to the blood vessel stenosis. And then after this, with further pressure, the alveolar process will distort, and if load is sufficient powerful and prolonged, then the tooth substance itself, that is the dentine, will distort. Advantages: the viscoelastic theory has been better accepted by researcher. Next is thixotrophic theory. The thixotrophic theory describes the periodontal ligament to behave like a thixotrophic material. The thixotrophic material is one which can undergo sol, gel and gel transformation. This theory considers the periodontal ligament to be collagenous thixotrophic gel and that fibers are only artifact. This theory has not been accepted. Now coming on to the short note. Discuss various indices that measure gingival bleeding. Now coming on to the short note. Discuss various indices that measure gingival bleeding. Coming on to the definition of indices. It is numerical value describing the relative status of the population on a graduated scale with definitive upper and lower limit, which is designed to permit and facilitate comparison with other populations classified by the same criteria and method. Commonly used indices for gingival bleeding are gingival index, modified gingival index, sulcular bleeding index and gingival bleeding index. Gingival index, that is the most commonly used index. It was developed by Lowe and Silness in 1963 for assessing severity of gingivitis and its location by examining the qualitative changes of gingival tissues. And all the teeth are scored, or either selected teeth are scored. Index teeth are 1, 6, 3, 6, 1, 2, 3, 2, 2, 4 and 4, 4. And the surrounding tissue surrounding each tooth is divided into 4 gingival scoring unit. And the scoring criteria is given here on the screen: 0, 1, 2, 3. And this is the most commonly used index. So coming on to the modified gingival index. Since it's a short note, it is necessary to write down all the indexes. I guess it's better to write only the gingival index. Coming on to the modified gingival index. Modified gingival index, the important changes, they are scored: elimination of gingival probing to assess the presence or absence of bleeding, redefining of scoring system for mild and moderate inflammation, then sulcular bleeding index, and then gingival bleeding index as it is given on the screen, and then papillary bleeding index. As I have already told you, it's a short note. It is not compulsory to write all the index. It is better to write only the gingival index in detail and to write only the names of other index: modified gingival index, sulcular bleeding index, gingival bleeding index and papillary bleeding index. And if you are having a fast handwriting, then you can write in detail all the indexes. Coming on to the next short note: define and classify gingival enlargement. So definition is increase in the size of gingiva as given in the Carenza. Current terminology is gingival enlargement or gingival overgrowth. Classification is given here on the screen. According to that, inflammatory, drug-induced gingival enlargement, enlargement associated with a systemic disease or condition, and neoplastic enlargement and false enlargement. And in order to score good mark, we can draw the diagram because it's very easy to draw. In this diagram, we have shown the gingival enlargement. And coming on to the scoring of gingival enlargement: grade 0, grade 1, grade 2 and grade 3. In grade 0, no sign of gingival enlargement, enlargement confined to interdental papillae, Grade 2 enlargement involve papillae and marginal gingiva, and grade 3 enlargement cover 3/4 or more of the crown. Now coming on to the differences between localized and generalized aggressive periodontitis. Now the definition: aggressive periodontitis comprises a group of rare, severe, rapidly progressive form of periodontitis, often characterized by early age of clinical manifestation and distinct tendency for cases to aggregate in the family. Classification: localized aggressive and generalized. The differences are given first on the basis of age. In localized aggressive, it is circumpubertal, that is near puberty, and for generalized aggressive, age is near about 30 years of age, but patient might be older. And distribution: in localized aggressive, localized first molar and incisor presentation with interproximal attachment loss and not involving more than 2 permanent teeth. And in generalized aggressive, generalized interproximal attachment loss affecting at least 3 permanent teeth other than first molar and incisor. Regarding severity, rapid and severe loss of alveolar bone loss, and in generalized episodic nature will be seen. And in etiology, predominance of aggregatibacter actinomycetam comitan, and in generalized, predominance of Porphyromona gingivalis. On the basis of immunological response, in localized there is robust serum antibody response to infecting agent, and in generalized there is poor serum antibody response to infecting agent. Regarding local factor, there is minimum amount of local factor in the localized aggressive periodontitis, but in generalized, marked plaque and calculus accumulation might be seen. Familial pattern: localized there is strong association, and in generalized the association is not clearly proven. Discuss periodontal manifestation of AIDS. Acquired immunodeficiency syndrome is characterized by profound impairment of immune system. The condition was first reported in 1981, and a viral pathogen, the human immunodeficiency virus, was identified in 1984. This is the introduction of our answer. Now, oral lesions strongly associated with AIDS are given here on the screen, but these are oral lesions. They are not the periodontal manifestations of the AIDS. Periodontal manifestation of AIDS we will be discussing later on. We will be writing only the points of oral lesion. We will not be discussing in detail. So first is candidiosis, oral hairy leukoplakia, non-Hodgkin's lymphoma, Kaposi sarcoma, and then periodontal disease. In periodontal disease, we will be discussing linear gingival erythema, necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis. So, and in the last, we will be discussing necrotizing ulcerative stomatitis. So, these are periodontal manifestation that will be seen in the patient of AIDS. So, coming on to the linear gingival erythema. It is characterized by marginal band of intense erythema that may extend beyond the mucogingival line and is associated with earlier change of HIV infection and CD4 suppression. No ulceration, pocketing or attachment loss, and strongly resistance to local treatment. The lesion may be localized or generalized in nature. The microflora is closely similar to that of periodontitis. Necrotizing ulcerative gingivitis is characterized by red, swollen gingiva with yellowish-gray marginal area of necrosis leading to destruction of interdental papillae. It might be of chronic or subacute form, spontaneous hemorrhage and characteristic fetid odor. May be associated with the pain. Necrotizing ulcerative gingivitis rapidly progresses and became periodontitis. Coming on to the necrotizing ulcerative periodontitis. It is necrotizing ulcerative rapidly progressive form of periodontitis which occur in HIV positive individuals. It is characterized by soft tissue necrosis, rapid periodontal destruction, interproximal bone loss. Lesion may be localized or generalized. Bone is often exposed, resulting in necrosis and subsequent sequestration of the bone. Coming on to the necrotizing ulcerative stomatitis. Severe destruction, and it is acutely painful, characterized by the necrosis of significant area of oral soft tissues and underlying bone. It may occur separately or may be as an extension of necrotizing ulcerative periodontitis. It is very much identical to Noma, that is Cancrum oris. Coming on to the next question, sign and symptom of periodontal pocket. Now, definition of pocket. Periodontal pocket is pathological deepening of gingival sulcus. Sign will be bluish red, thickened marginal gingiva, bluish red vertical zone from gingival margin to alveolar mucosa, gingival bleeding and suppuration, tooth mobility and diastema formation. Symptom. The disease is usually painless, but sometimes localized and radiating pain might be there. Localized pain or pain deep in the bone, sensitivity, foul taste, teeth might be loose, feeling of itching in the gum. And we can write classification also. So the classification of periodontal pocket on the basis of connective tissue loss, true and false pocket, and true pocket, further suprabony and infrabony. On the basis of surface and wall, simple, compound and complex, and on the basis of healing, edematous and fibrotic. Coming on to the one-liner question, width of attached gingiva. Pristine gingiva. Keratin found in outer epithelium, bundle bone. By Russell index is called as composite index. Who coined the term biofilm? Now coming on to the width of attached gingiva. Width of attached gingiva is the distance between the mucogingival junction and projection on the external surface of the bottom of the gingival sulcus or periodontal pocket. And the width of attached gingiva is greater in incisor region, 3.5 to 4.5 millimeter in maxilla, 3.5 to 3.9 millimeter in mandibular. Incisors, it is least in premolar area, 1.9 millimeter in maxillary premolar and 1.8 millimeter in mandibular premolar area. Pristine gingiva, a state of superhealth where normal gingiva is free from significant accumulation of inflammatory cell, according to American Academy of Periodontology. Keratin found in outer epithelium. Orthokeratinized area contain K1, K2, K10 to K12, that means K10, K11 and K12. Highly proliferative area contain K6 and K16. Stratification specific is K5 and K14, that is present in the outer epithelium. Coming on to the bundle bone. Bundle bone, it is histological term. First of all, the most important thing is histological term for the portion of bone of alveolar process that surround the teeth and into which the collagen fiber of periodontal ligament fiber are embedded, and it is more calcified as compared to the other area. Next question is why Russell index is called as composite index. It is called composite because it records both the reversible changes due to gingivitis as well as irreversible changes by the periodontal disease. That is why it is called composite index. Who coined the term biofilm? The biofilm was coined by Bill Costerton in 1978. Thank you so much.